Last week, the Phoenix Suns lost starting forward Cam Johnson to a knee injury. Incredible. He was literally just walking across the court, took a wrong step. Here's a professional athlete who exposes his knee to unbelievable forces on a daily basis, and that was somehow enough to cause a meniscal tear. Cam's undergone an MRI. We're told in the press that he's set up to have surgery. We wanted to give you guys some more background and some understanding of what a meniscal tear is, what that means, and we wanted to get it from a true expert. So today I'm very fortunate to have Dr. Philip Benyon with me for an interview. Dr. Benyon is a board-certified orthopedic surgeon who specializes in sports medicine. That means he specializes in arthroscopic surgery of the shoulder as well as the knee. We don't know what surgery Cam is going to have, but it's going to be an arthroscopic knee surgery. Doctors like Dr. Benyon cannot comment on individual players. He's not Cam Johnson's doctor, but he is someone who is an expert in this area, so he can open up with us about what Cam Johnson's looking at and give us the background on meniscal tears and how to manage it if something like this were to happen to you. Dr. Benyon, thanks for joining us on the show.
Good to be here.
We just wanted to ask you with Cam Johnson's recent injury, and I know you can't tell us anything specific about him and wouldn't ask you, but just in general, a lot of people are asking questions about meniscal tears. They're so common. I understand this is one of the things that you see on a routine basis.
Absolutely.
And if somebody has a tear of their meniscus, they have knee pain, what else would clue them in that what's going on is a meniscus and not, say, an ACL or some other kind of problem?
Well, a meniscus tear tends to be pain that's right on the joint line. So if you think about the knee, right on the inside or the outside of the knee, right along in a horizontal line on either side is where the pain typically is. And another feature of meniscus tears is that they tend to be associated with mechanical symptoms. So you want to be looking for popping, clicking, catching, or locking of the knee. And specifically, when those things occur, it's a painful event. So we all have, many of us, noisy knees where we bend and straighten our knee. We feel the grinding that happens, but that's not a painful event. We're talking about something that's definitely wrong, almost like having a rock in your shoe. You definitely know when you need to take your shoe off and get that rock out. This is the same kind of sensation in your knee, and that can be a displaced piece of meniscus that now is causing that mechanical symptom.
A lot of people talk about locking of the knee as being highly specific for the meniscus. Is that true, or is that just?
It is true.
That is true. Okay.
Yeah, and locking is really when you go to try to bend or straighten your knee, and it gets kind of stuck in a position, and you have to kind of reconfigure the knee. Maybe you're getting out of bed and you can't quite put your foot down on the ground yet because it's stuck in a certain position, or you're walking and then it doesn't want to move because of the pain and you have to stop and reconfigure that knee. That's what locking acts like.
That sounds terrible. Now, what about MRI is the test of choice, I assume, to demonstrate a meniscal tear?
Well, it's the imaging test of choice, yes.
So what do you think of the physical exam?
Well, the physical exam is really important, and it's important for people to remember that we're not just treating the imaging, and commonly people do come in with MRI imaging, which is great, but we really want to take that in the context of the history of the patient and also the physical exam. And on physical examination, there are some very specific types of examination items that we do in the clinic to make sure that the imaging findings that are there are consistent with the patient's pain. In other words, patient that comes in with something like sciatica with pain coming down the leg, but happens to have a degenerative meniscus tear that really is not causing symptoms, we wouldn't necessarily jump on that with an urgent surgery, for instance.
You have to match up the imaging with their actual symptoms and what you actually see on examination to make sure you don't get a false positive on the imaging.
Well, if you want to take care of the pain, that's what you have to do. And unfortunately, sometimes we have to inform our patients that we're here to take care of your pain, and so let's find out what that is, and the imaging may or may not line up with that.
Yeah. Oh, that's so interesting. Well, so let's say you had an MRI, it did show a meniscal tear, someone comes in to see you, what's the first thing you do? Are you going to give them a steroid shot or Sometimes do you go right to surgery? How do you decide what to do?
Well, we really need to tailor our treatment to the patient specifically, and there are so many different factors.
Mhm.
But yes, we do perform steroid injections for meniscus tears. Oftentimes, we will do some physical therapy. If the knee is really inflamed, and sometimes the knee does fill up with fluid in response to a meniscus tear, we'll pull some fluid off of that knee and maybe put some steroid in. If that situation where we do identify a tear on the MRI scan, we may go ahead and just sign that patient up for a surgical procedure to go in there and restore that meniscus. So it really does depend on some demographic factors, some historical factors, how long that meniscus tear has been there, is there any osteoarthritis, just so many different factors.
Everyone's different, and so you really have to go on a case by case basis to get the best possible
Absolutely.
result. Well, that's why we need a specialist, right? It's
Yeah, I mean,
complicated.
there's no substitution, at least so far, even in 2020. I'm sorry, 2022. We still don't have a substitute for human beings, which is
Yeah,
good for us.
yeah, for sure, and good for our patients, to be honest. Okay, now if somebody does end up, you've done everything, you drained it or whatever needed to be done. As it turns out, they're going to need surgery. What makes it more likely that they would benefit from a repair versus just a debridement, a meniscectomy? How do you make that decision, or what's the kind of calculus there?
Well, we do try to determine that based on the historical findings. Who is this patient? Do they have a lot of degenerative changes in that knee, or is the knee otherwise pristine? How active is the patient? And then ultimately, when we get into an arthroscopic surgical situation, we go in there and we look at the meniscus itself and determine what condition that meniscus is in and exactly where that tear is. So if the tear is, for instance, close to the capsule or the outside of the knee where the blood supply comes in to feed that meniscus, then we're a little bit more likely to repair meniscus in that situation because we know that the blood supply is likely to be sufficient to go ahead and help us glue that meniscus back together after we sew it. If, however, there's a tear in the inner aspect of the meniscus where there really is no blood supply, there's very little chance of a repair healing, and so we don't attempt it. If we do have to attempt to repair in that situation and it fails, then we would end up having to maybe come in for another surgery to repair that or to debride that meniscus. And so we try to be very careful which ones we repair and which ones we don't.
I really like your approach that everyone's different and you want to get the best result for every patient depending on their circumstances. But we do frequently get questions from patients who say, "Oh, I saw this doctor and they told me I'm over 50, therefore I can't have a meniscal repair. I can only have a meniscectomy." Do you subscribe to that? Are there hard and fast rules that you have to follow to get a good outcome? Or is it, as you say, more individual?
It's really individual. So we really try to treat that individual patient according to their physiology. So we all know people who are maybe it says 75 or 80 years old on a piece of paper, but you look at that person and you know that they're much more vital. Maybe this person's playing pickleball 5 days a week and
Hmm.
competitively. So we really do cater it to that patient. And so there really is no hard and fast rule when it comes to repair. It does have something more to do with the patient's expectations. And of course, can that patient undergo the rehab for a meniscal repair, which is significantly more extensive than for a meniscectomy? But if a patient qualifies, then we go ahead.
And what is that kind of for meniscectomy? It seems like I've seen your patients; they're up and at it within days. What is the repair?
Mhm.
What is the recovery from a meniscectomy compared to a meniscal repair?
Well, a meniscectomy is a very simple operation, of course, and it's done through poke holes. We go in with the camera and we just clean up that meniscus and debride it and remove any of that offending tissue that's getting in the way. And this is a meniscus that usually can't heal anyway, and so we're just kind of cleaning that rock out of your shoe, so to speak. When we do a meniscal repair, it does require that we protect that repair long enough for that blood supply to come in and glue that meniscus back together. And so it does require that we immobilize the knee in a brace, usually, sometimes non-weight bearing. And we also modify the amount of flexion and extension, bending and straightening of that knee. And there's a lot of supervision that we get from the physical therapy specialists. And that course of physical therapy goes for 6 to 12 weeks, and the initial immobilization is about 6 weeks. So for a month and a half, that patient's going to be on crutches, and that may affect their leisure activities and their work activities. So we really do talk a lot in the clinic in advance of a surgical procedure to just make sure that the patient knows that if we do find that type of situation and we do attempt to repair, then that's what's going to be expected on the back end.
And what's the advantage of a repair? That's a lot of recovery. If you could just go in and clean it out and you're good to go, what do you get out of all that? What's the return for the patient?
Well, we think that by preserving the meniscus, we preserve the anatomical function of the meniscus, which is really a shock absorber for the knee. So we hope to preserve the knee's ability to not degenerate over time.
Hmm.
So we do know that if we don't have a meniscus, then that knee is susceptible to advancing in terms of osteoarthritis faster than it otherwise might have. And so we do try to preserve that meniscus when possible. But then, of course, we have to weigh that in the context of all those other things that we talked about.
Another question, I'm sorry to backtrack, but we get a lot of people who really are struggling financially or in other ways. It's going to be hard for them to move forward with surgery. They really want to wait and see if this thing will heal on its own. How long would you recommend somebody wait it out before seeing a surgeon like you if they didn't want surgery, if they wanted to just try to go? And then at what point are you sort of, look, it's probably not going to continue to get better. It's time. If you're going to get surgery, now's the time.
Well, I think it's always good to know the enemy that you're dealing with here.
Mhm.
So sometimes we have patients that come in, they think they have a meniscus tear, and it turns out they have something completely different. So I always encourage people that if this knee pain has been there for more than a few weeks, and if you have a limp and you're not able to go out and hike or do the things you want to do, then come on in, get an X-ray. Maybe we get an MRI scan, or maybe we don't get the MRI scan right away. Maybe we just give you some advice and allow you to overcome this injury and then follow up conservatively. So I think that if the pain persists beyond a few weeks and it's impacting your ability to sleep or do other activities, to come on in and have it evaluated.
So, as a sports medicine orthopedic surgeon, it's normal for you to follow patients through this whole process from even before they have any imaging to all the way through, if necessary, in some instances, to surgical treatment.
Absolutely. So we see a lot of people who come in, we get some imaging, we send them out for treatment, and we follow them out for maybe 6 weeks or even 3 months or beyond. And many times we do not even do surgery for those patients. So I wouldn't uh, necessarily, I would tell somebody that they don't need to worry that just because they're coming to the surgeon that we're going to take them right into the OR. So
Yeah.
a lot of the treatment we do is conservative.
I hear that all the time from people. Oh, if you've only got one tool, then if you've only got a hammer, every problem is a nail. Surgeons do surgery, and that is absolutely not the case. Surgeons manage problems, and sometimes when it involves surgery, part of your job is to separate out those two things and advise people what you think is the best course for them.
Absolutely.
Yeah, very interesting. Last question now. If somebody, not Cam Johnson, but like a Cam Johnson, a very, very high stress, high use athlete, maybe even on the professional level, if they did not move forward with any sort of intervention and they just experience natural healing, I'm sure it depends on the person, depends on the tear, but what's kind of the range for, they're not going to get better in a few days, right? What is it, weeks to months or days to weeks? What's natural healing like for that kind of a person?
Well, we have to think about the initial effects of the tear and then the initial effects of a surgical procedure and the natural process of healing thereafter. So, as you said, it really does depend on what you end up doing, if you do a repair or meniscectomy or just conservative treatment. But the initial injury is going to create some inflammatory mediators within that knee. The knee is going to be inflamed, and it may take many weeks for that effect to go away just with conservative treatment. If we do an additional procedure, a surgical procedure, that procedure itself is going to kind of bump up that inflammatory process a little bit, and that initial process may take a week or two until that subsides, and then to get back to full sports and full work activities, it may be weeks to months after that.
Now, what is return to, if you had meniscectomy, what is return to play typically?
So a meniscectomy return to play could be as soon as 4 to 6 weeks with a more advanced recovery situation. And return to work for a non-athlete might be similar, might be sooner. We've certainly had patients that undergo a meniscectomy procedure and then go back to work within 7 days. So a desk job maybe even sooner than that.
Yeah, it's got to be enormously more force on that poor inflamed and healing knee to go back to professional athletics, certainly, or any kind of
Oh,
athletic.
absolutely.
Yeah. All right. Well, that's fascinating. Thank you so much for being with us today. It's hugely helpful. Any final thoughts or comments?
No, just thank you so much. It's always fun talking about this stuff.
Yeah, again, thanks for being on the show. Wow, fascinating. I love Dr. Benyon's approach that every patient is different, every person is different, and a real doctor is going to take all of those individual things in mind and in consideration in coming up with the very best plan for you. On the other hand, there are certain guidelines which you can use to sort of give yourself a sense of what to expect and then be pleasantly or maybe unpleasantly surprised at how it goes down in your individual case. Everyone here at Best Practice, and I'm sure all of you are wishing Cam Johnson a speedy recovery. This young man has everything to look forward to. Brilliant athlete, starting professional basketball player. We really wish him the best, and we'll let you know how he progresses when we hear more about his surgical results. Have a great day. Now listen, don't forget, if you have questions about yourself, forget about Cam Johnson. What about you? If you have questions about your knee, that's something either I or maybe even we need to get Dr. Benyon on the line to advise us about, click through and send them to us. I'd love to learn more about you, what's going on, and figure out and make sure you get the very best practice. For Best Practice, I'm Dr. Dan Lieberman. If you have a question you would like answered on Best Practice Live, there are 3 ways to ask. Leave a comment on any of our social channels, click the link to our website and complete the submission form, or call or text us at 608-602-4022. The more information you can give us, the better we can answer your question. So please contact us and we can walk you through uploading your imaging to a secure server. Please like and subscribe to our channel to stay up to date with information about your spine and joint health. Lastly, be sure to check out new episodes at 10 a.m. Pacific, 1 p.m. Eastern, where we answer all your questions.